So moving on to our second topic for today, Sanger versus NGS for mutation analysis, applicability in real-world Latin America. I'm delighted to welcome, although they've already made their presence very much felt, Dr. Isabel Giere from FUNDALEU in Buenos Aires, Argentina. As you've already discovered, Isabel brings with her a wealth of experience in the laboratory, and I'm so pleased that she will share some more of it with us today. Welcome, Isabel. And last but never least, Professor Jerry Radich, another giant in the CML field. He epitomizes the expression of, if you want something done, ask a busy person. He is involved in so many things and is in such high demand, yet he somehow always manages to find time for the foundation. And we're very grateful, as always, for his contribution. So I will take my slides down and I will invite Isabel to get her slides up. And as she's doing that, I'll let the audience know that Isabel and Jerry will run their session very much like the first one. 2 cases presented, one after the other, questions and discussion from Jerry, Isabel, our other experts, and you, the audience, after that. Isabel, you are ready to go. Over to you. Thank you.
Thank you to all for joining this event. And well, I come from Argentina. I don't know how to. Here. I come from Argentina. I work in FUNDALEU in Buenos Aires. Buenos Aires is the capital of the country. And I have a little group, Teresa and Rocio, and well, we were called together since many years ago. So case 1 is a 39-year-old male CML patient diagnosed as in chronic phase with a low SOCAL score. So here are the parameters at diagnosis. He showed splenomegaly also and hepatomegaly. The transcript levels was high, 98%, and the treatment selected at that time was imatinib. By the persistence of splenomegaly, the dose was increased, and after a year, the patient achieved MMR. Here we can see how the transcript level decreased. And at that time, the spleen reduced also. So during 9 years, from 2008 and 2017, due to incomplete adherence variability, here we can see in the transcript level was observed, but the MMR persisted. In 2017, 10 years from diagnosis, the patient was referred to our health center for molecular monitoring because the transcript began to rise here at that point. So we performed the analysis, and the transcript level increase was reconfirmed in our lab. Molecular relapse, understood as the MMR lost, was detected twice here in that point. So, well, in that moment, mutation analysis for the kinase domain were conducted according to the recommendations of that moment. We performed the PCR for detecting the T315I mutation with it is an allele-specific oligonucleotide PCR. We can see here the band, the amplicon of the mutation. And in the same moment, we performed the Sanger sequencing, and the same mutation was detected. Well, nilotinib was the second-line TKI, and the MMR was observed at 3 months from the point of change now, here. And deep molecular responses were detected with the, the patient became in deep molecular responses, but with detectable transcripts always in each assay. Due to a complete adherence, patients had sustainable and lasting deep responses in MR 4.5. Here we can see till today. Well, in this case, the mutation analysis were performed after confirming molecular relapse. Sanger sequencing and ASO-PCR revealed the T315I variant. Although it is known that the CML patients carrying this mutation are generally resistant to TKI, surprisingly, this patient achieved optimal response with nilotinib. The only therapy change he was eligible for at that time, and he achieved deep molecular responses over the time. Currently, these patients would have been treated with another TKI as ponatinib. In Argentina, this TKI, ponatinib, was approved in January 2023. So, the questions, in your experience, have you ever had a T315I positive patient who responded to nilotinib or other second TKI? And the second, how can we explain this outcome?
Thank you very much, Isabel. We will go to Giere first, please. What are your thoughts?
Well, this is obviously, well, first off, I have to commend Isabel because we talked about the importance of doing confirmatory testing of T315Is in unusual circumstances, and she's already done it in this case. So she's already we have 2 ways of testing it. So well done. So I believe it. Yeah, it's rare, but I have seen cases that have responded. And you know, it's not only 359, but it's all of, you know, when you showed the heat map of the predictions of responses, and not uncommonly you'll see someone who was switched from, you know, from one drug to another, and they're responding, and then you go back and get their sequencing done, finally comes back a month or 2 later, and they shouldn't be responding at all, but they do, right? And so why is this? It's because one, the depths of our what we know and understand is pretty limited. Cancer is an ecosystem, right? The cancer cell is only one part of it. The other part is, you know, drugs and drugs levels. I'm sure that every patient has different metabolism of these drugs, and some may have a relatively low amount of drug and some a lot. So this person may be getting enough nilotinib that's overcoming any resistance. You have the microenvironment, you've got the immune system. There's lots of things that go into the pot that we don't understand that measures and predicts that influences response. So that's one of the fun parts of medicine. There's a lot out there that we just don't understand, and this would be yet another example of that.
Lillian, what do you think?
Well, I have seen a few patients with this mutation in my hospital, but I hadn't read that they could be sensitive. So maybe it's similar to my case, in which the transcripts level were so low that it makes it the patient more sensitive, but I'm not sure.
So,
Yeah, that was one of the things that I was going to say as well. Was it because the patient was treated very rapidly while the BCR-ABL was low? But we've seen many cases where we rapidly see T315I that can grow out. When we track back, we can find low levels prior to a patient switching to a second generation TKI, T315I emerging. So it is unusual. And just one other thing that I thought was important to highlight is, again, the importance of adherence. So this patient, I think you said they had non-adherence. There were some times of fluctuating BCR-ABL up and down. Whether there are some patients who this just generates an environment for mutations to occur. So, perhaps this may have contributed to the patient acquiring a mutation so late after the start of TKI. So again, I think it's just the importance of adherence over time.
Yeah. No, I think I wrote down in my notes here, Sue, Bruce Ames. So I bet I'm the oldest person on this call by ages. So Bruce Ames was a biologist at UC Berkeley who was one of the first people who figured out how to make microbial and cancer cells resistant. And how he did it was by giving intermittent doses of suboptimal amounts of drug. And after a while would very select out clones that were resistant to the drug. So patients like this one are essentially performing an Ames test on themselves. They're basically creating the ideal situation for clonal resistance to occur, because you're just putting enough selective pressure on that it allows resistant mutations to come out. And Darwin usually wins. And this is another example of that.
Isabel.
Yes. I keep on with other slides.
Any other comments just to wind up this?
Okay. Yes. Well, I think that this case is a special case, an exceptional case. Without any doubt, there are other reasons of his evolution, and we don't know all about the mechanisms. Perhaps we have to keep on monitoring the mutation. Thinking about the transcript level is detectable, low but detectable, very low but detectable. So I think perhaps we could perform a PCR, allele-specific nucleotide for this variant to search if we can detect or not it during his monitoring.
So I think, Isabel, you can probably move on.
Yeah. Wait. Well, do you hear me? Yes.
Perfect.
Okay. Well, so as an academic topic, the loss of MMR under TKI therapy is an important failure criteria, and these mutations occurs blocking the binding of the pocket of the nilotinib and other TKIs like imatinib in the pocket. We know that there are many heat maps with the values of the concentration of the TKIs, but those in these maps we can see how the sensitive of the mutation is to the TKI, but it is an in vitro data, no? In vitro potency data. So we know that generally patients carrying this mutation are resistant. And well, the use of Sanger sequencing we know is acceptable. It's a fast and easy method over the world. Well, this method does not represent an inappropriate management of patients, so it's the method we have nowadays. And well, however, the patients resistant to asciminib, mutation screening should be extended to include relevant regions outside the tyrosine kinase domain. We in Argentina, we have only the Sanger sequencing method as possibility to evaluate the patients. We don't have the possibility to evaluate by NGS the kinase domain. That's all.
Thank you, Isabel. So I think that in wrapping up that first case, I might just invite some last comments from our experts if they have any.
Okay.
And also, we'll just address this question from Mariana Lorenzo, thinking about the variability of TKI responses. Do you check for pharmacogenetics variants? Jerry, would you like to have a go at that as we...
I didn't get the last part of that sentence. Do you check for?
Pharmacogenetics variants.
Boy, I wish you could. There's very few labs that are doing that. Probably because the response tends to be so good that they don't see the long sustainability of doing it. But in every cancer drug that we've given, that someone finally devised a pharmacological way to look at levels. The variation in humans is huge. It's like tenfold, right? Across, you give the same dose to people and then monitor them. Every drug pretty much has a huge variation, and I'm sure that explains a lot about what happens with responses and toxicity, right? But right now there haven't been a lot of biters out there I don't even know if I could find someone to measure pharmacogenetics with these tyrosine kinases around here.
Lillian, what do you do?
Hope you're mute.
No, we just follow the reference heat maps for choosing the TKIs. We don't have any pharmacogenetic studies.
Okay, and Sue, how about you?
No, we don't do any of that. And I think, as Jerry explained, it's perhaps more than just genetic variability. There are a number of other factors that may influence.
Thank you. Okay, Isabel, you want to, if you have a comment on the pharmacogenetics variants, let us hear, and otherwise you can go to case 2. Thank you.
Okay. Ay, ¿qué pasó acá? No. Case 2. Yes. Well, the second case is a 44-year-old male patient with chronic phase CML in an intermediate SOCAL risk score. Splenomegaly, leukocytosis, and with a very low percentage of myeloid blasts at diagnosis. This is the karyotype. And the BCR-ABL fusion transcript was positive, B2A2, the isoform of P210. And in that moment, the level at diagnosis was 83%. The TKI selected was dasatinib, and he showed 100% of adherence to the treatment. The molecular monitoring in the first period of the monitoring, at month 3, he showed less than 10%. And at month 6, he showed MMR, but at month 12, he lost MMR with an increase of the transcript of the just 11%. So increase was reconfirmed in 2 assays later at months 13 and 14, and the increase was very important. At that moment, between months 13 and 14, in this period, a blast crisis occurred, and the molecular analysis at that moment were conducted. The PCR for the T315, the Sanger sequencing with no variants detected, another molecular tests, typical from acute myeloid leukemia, and were negative all, no detected. And the new generation sequencing of a myeloid gene panel was performed, and 2 variants of this gene, GAGE2, were detected. Here we can see the NGS of the myeloid panel, 2 variants in the same gene, GAGE2, pathogenics both, one with a buff of 15%, the other 33.6%. And also, this panel could detect, obviously, the fusion transcript, BCR adders. Well, GAGE2, both were pathogenic variants. We interpreted or understood that the variant with a buff of 15% was expected as germline. And well, in that moment, germline studies were not available. Well, at that moment, in blast crisis, with this profile, genetic profile, the patient started chemotherapy with this treatment as azacitidine, venetoclax, and ponatinib. And at the same moment, we began the searching of a donor, a related donor, for an allogenic stem cell transplantation. Well, the molecular monitoring during this chemotherapy revealed that the transcript level first decreased, but then start to rise again. Here we can see from month 12, during this period, at month 18, the rise was very important. But the blasts in bone marrow decreased. Although the percentage of blast decreased over time, the transcript expression remained high in this point. Well, patient in November of 2022, here at that time, here is the highest level of transcript, but patient showed hematologic remission without molecular response at that point in this timeline. So patient underwent allotransplant here in hematologic remission with a myeloablative conditioning. But in 2 months, 2 or 3 months, yes, graft failure occurred and an early relapse with 2% of blasts in bone marrow was observed here. In that point, at failure, the level of the transcript was 96%, with a karyotype of a mixed chimera with cells of the patient, of the host, with a translocation with a little number of cells of the donor, unrelated donor, a female donor. So on March 2023, in March, he started the TKI therapy with ponatinib. And then, after a month, patient showed clinical complications related to the transplant and died. So this male CML patient was adequately evaluated, although his abrupt clinical course was likely associated with an adverse genetic background detected at the time of the blast crisis. Although the treatment and the donor searching times did not allow for faster treatment, it was decided to give him a therapeutic opportunity, even though the chances of success were very low. So the questions: would it be clinically useful to know the genetic background of a myeloid panel, in all neoplasms at the time of diagnosis? It would be clinically useful to know. And the other question is, how would you manage a CML patient with germline predisposition to neoplasms and suboptimal response to the first line of TKI? So if we imagine this timeline, a diagnosis would be better to perform the analysis in here at this time or not? Would be the same therapeutic approach?
Thank you, Isabel. What an interesting case and great questions. We will start with Giere, please.
And the cases keep getting wilder and wilder. What's going on in Latin and South America? It's real big. Yeah, so this is a wild case on many things. You said it's very early blast crisis. You typically see blast crisis after you've undergone selective pressure with a number of tyrosine kinases and having resistance and the like. So this could be an unusual presentation. And the GATA, it looks like this patient has a GATA insufficiency, which is, a haplo sufficient genotype. Typically those cases, they have a very variable outcome, right? Even siblings who have the mutated GABA can have very clinical different courses. Since it's a stem cell disease, and you often get disturbances in your immune function with your lymphoid and NK cells being out of whack. And then the ones who don't have major infectious complications often evolve to some type of myeloid neoplasm, usually starting out with MDS. They can go to AML or CMML. I think going into CML is almost a reportable case. That's really rare in the diagnostic setting. So what you would do, with this particular case, typically patients who have GATA2 mutations and don't have any evidence of going on to a myeloid malignancies typically don't get transplanted, they just get monitored. But here you've got a case where they've already in CML, at diagnosis. This might be one of the rare cases of chronic phase CML that you might consider transplanting sooner than later. But again, this would be like 5 cases, in a lifetime. But this might be a case where you'd at least think about it, because of the high suspicion that this could go on and have bad things happen. Once they relapsed into post-crisis, then I think everything was still done, absolutely appropriately. This person just had bad luck. The bad luck, and what it showed with the BCR-ABL and the like was that you were able to, clear out the blast population with the chemotherapy pretty well. That's likely the population that has the germline GATA and the acquired GATA, so they have a biallelic disease. So I would bet if you had done next generation sequencing when they had a high BCR-ABL level but low blast, you'd see the one GATA mutation in the germline, but not the other one. That would be my guess, if you had that data. And then their luck persistently bad. The graft failure rate for matched unrelated transplants with a myeloablative regimen is probably well less than 5%. I haven't seen one in a number of years. And so that, happened as well. And that might just be the backbone of the bad microenvironment given his, disease and the like. So the bullet point would be critically useful to know the genetic background in all myeloid neoplasms. That's, I think, certainly true if you can afford it, if you have the technology. In CML and chronic phase, we don't know how to use the data. Sue's given some very nice talks on this, although the AXL1 mutations are looking kind of suspicious. But certainly in the guidelines, at least in the NCCN, for chronic phase disease, they don't advocate doing anything differently except maybe worrying a little bit more if they have mutations. But I think that we have to brace ourselves and get ready in clinic, because pretty soon this is going to be routine in all kinds of myeloid malignancies. And we just have to face the fact that it's going to be a long period of time until we know how to deal with all the data we're getting. Not only specific mutations, but combinations of mutations, which probably are going to behave very differently. If you have mutation A, B, and C, it's probably going to be very different than A, B, and D. And so it's going to take tons of data to get that. But I think that physicians and patients are going to be demanding that we go in that direction.
I think they will. Lillian, what are your thoughts?
I was wondering if the donor was related or unrelated. I didn't quite see
I think I
that.
said unrelated.
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 Yeah,
Okay.
Yeah.
So he didn't have the same mutation.
Yeah, they wouldn't do that.
Well, as you said, only ASXL1 is the one that's been associated with a worse prognosis from diagnosis. So all the other ones are still not of clear clinical value. So sometimes having more tests is more confusing for the clinician.
Sue, what are your thoughts?
Okay, so I was really fascinated by this case, Isabel, because I'm not sure that at least one of those, the 18 base pair deletion for the GATA2, that is a recurrent somatic mutation. So I think perhaps, and we know that germline mutations have implications for family members as well. So maybe one of the things that if you suspect that it is germline, that it may be important to refer the patient and the family to a geneticist. But we have a case of a patient who was diagnosed in accelerated phase. And this was a patient we published in 2018 who had the exact same 18 base pair in-frame deletion at diagnosis. And we were able to confirm that it was somatic. So this patient initially responded very well to imatinib, had undetectable BCR-ABL, but then 4 years after diagnosis progressed to blast phase. And what's absolutely fascinating is that they gained a second GATA2, and it is the exact same GATA2 mutation of your patient. So that's going to be more than chance. So there's some biology there. So
That's wild.
yeah, and GATA2 is so rare. We've looked at maybe more than 60 patients in blast phase, and we've only detected 2 patients with GATA2 mutations. One of them was this patient. So I think, yeah, the point from this is if you can confirm whether it is a germline or not, maybe this was a somatic mutation, and it would be great if you had the opportunity to go back perhaps and test the diagnosis sample using NGS to see whether it was both of those were present, whether they were acquired. So a really fascinating case.
It's wild.
Yeah.
Absolutely.
Thank you. As we move forward with this discussion, a couple of questions that have popped up in the chat. Do able gene additions and deletions have prognostic implications? What follow-up do you recommend? That comes from Ana Inés Prado from Uruguay, who then follows up with, do you use prophylactic DLI associated with TKI after transplantation in patients at high risk of relapse? So as we move forward in that discussion, we'll come back to Isabel because you still have some comments on your own case to make. But if we could try and incorporate responses to those questions as well, that would be great. Isabel, back to you.
Well, so about this case, the mutations in GATA2 can be present in germline or arise somatically with a clinical consequential. Somatic mutations have been reported as drivers of myeloid neoplasia, including myeloproliferative neoplasms, myelodysplasia, and acute myeloid leukemia. And these mutations confer generally a 90% lifetime risk for developing of this neoplasia. We know that frequently mutated genes at diagnosis are these 3 genes, and here we can see an interesting report of Sue Branford about relevant variants in blast crisis, and here GATA2, 82. We can see the frequency is less than 5%, very, very low frequent. And these patients, well, fall in this percentage of cases. Sue also reported a potential future NGS strategy in CML patients, divided into groups, chronic phase patients and in blast crisis. If chronic phase a diagnosis, well, we can see if they are low or intermediate risk. No sequencing at diagnosis, but when lack of the TK response, we have to perform the Sanger sequencing or the NGS for the BCR-ABL tyrosine kinase domain plus NGS. If it is high SOCAL risk, NGS in the beginning, and then after loss of response, well, the Sanger sequencing or the NGS for BCR-ABL fusion transcript and NGS also. But if the patient is in blast crisis, well, all the studies must be performed. So the detection of specific variants at diagnosis may contribute to risk of treatment failure. Approximately 15% of patients with TKI resistance acquire mutations in the tyrosine kinase domain. NGS will identify other somatically mutated cancer-associated genes that contribute to resistance. And well, genomic analysis contributes also to the selection of therapy, drives drug development, and well, more importantly, leads to better outcomes for CML patients.
Thank you so much, Isabel. We might do one last round of comments from our experts, commenting on Isabel's second case and those questions that popped up in the chat. Jerry.
Yes, I can. Well, I can. I want to make sure the questions get answered in the chat. All right. So, Isabel, great job. That summary was excellent. Don't have anything to add to that. But since I'm the transplanter here, I'll answer the question about what to do with people with high risk of relapse. So, typically, if a patient has, either accelerated phase of blast crisis when they go into transplant, presumably you put them in some kind of deep response. We'll start prophylactic DLI as soon as they engraft. And it really depends which one you pick. Depends on a couple of things. One is how does the patient look overall, graft wise and the like. When they've recovered the graft, because imatinib you can give people as soon as they engraft, and it doesn't affect counts at all, and they tolerate it really well. All the second generation drugs in ponatinib really hit their counts hard, which is hard when someone just starts to engraft. You won't lose the graft, but you'll suppress it, especially the platelets. So you have to be careful there. Nilotinib has the advantages that it actually works on GVHD, so it's actually you can kind of kill two birds with one stone. Although if you're relying on the GVL effect, that may not be the best choice either. So you can start. We typically don't do DLI just prophylactically because I'm kind of even though I've been doing transplant for 40 years, I'm pretty much a DLI skeptic. I don't know if I've ever cured anyone with DLI. I have, however, killed people from GVHD using DLI. So I'm usually kind of that's a last resort for me. I would rather almost go to a second transplant if I could. So that's our approach at least.
Thanks, Joe. Lillian?
I have a question on really because I was asking around in the different labs in Chile what test they use, and in some labs they use homemade assays, and in most of them they buy kits, but some are approved only for research use only. But with all the due quality controls in your countries, how do you regulate that? Do they have to all use kits with IVD approval or FDA, or all the clinical labs, I mean?
In our country, you can use tests as long as you basically have done all the CAP/CLIA validation work yourself and prove that it works in your hands with the adequate controls and stuff. So it doesn't have to be FDA approved at all. I mean, up until a few years ago, there was no approved FDA. Cytogenetics isn't approved for CML by the FDA, let alone most of these other things, right? So you can use for research only kits and the like, as long as you've done all the validation work yourself and can show it to the regulatory agencies. The FDA was trying to get involved and demand that all of the tests that people like us do in labs met FDA approval, which was nuts because they don't have enough people to do that. And that would have essentially, most labs would have not done any testing because that would have been unbelievably expensive and the like. So that died. So we're still, as long as we can kind of show the assay can work, we're okay.
Okay, thank you.
Maybe Isabel, and then a last comment from Sue.
So,
Isabel, do you have any last comment? And then Sue?
well, my comments is that the way we work in Latin America is very in the capitals and in the great big cities, we work better than in the countryside. Yeah. And our quality controls are locally. There are national programs for some assays, but not all. And some other assays are checked by the CAP. We enroll in the CAP quality control of USA, but not all of the assays. Yes. I think that it would be better to centralize in the region for NGS, for CML transcript sequencing, for example. And well, for the other studies, for example, for NGS in CML, I would like to send the samples abroad to Susan Branford or Sherry, because we cannot perform those tests nowadays. That's the real world.
The reality, of course. Sue, last comments perhaps from you. You have your choice of which of the issues you'd like to finish on.
So I can address the question about, do able gene additions and deletions have prognostic implication? And certainly there is a 35 base pair insertion that is very, very common. And there is also an exon 7 deletion that is very, very common. And I would just say that if you see a report with either of those two, there is no evidence, as far as I can see, the work that we've done, that they cause resistance to any of the TKIs. So they're extremely common. So I would say, even though some labs do like to report them, we often get emails from clinicians to say, what does this mean? And we have to say, we don't think it has any meaning. It plays no role in resistance as far as we can see, because we detect it in patients who are responding as well. And even in patients with undetectable BCR-ABL, we can detect these particular things. So that's the last thing I had to say.
Thank you. Thank you so much. And unfortunately, we are out of time. Thank you very much, Dr. Lilian Pilot, Dr. Isabel Giere, Professor Sue Branford, and Professor Jerry Radich, and of course, our interpreter, Veronica, who has hung in there over time.
There you go, Veronica. Thanks, Veronica.
We appreciate it so much. And thanks, of course, to all of you, the audience, for joining us today. I will send links to the recording of this session as part of a post-event package that we'll send to you tomorrow. Please visit our website and the Knowledge Center. It's packed with great learning, and feel free to contact me anytime if you need any help with any CL matter, because we are very well connected, as you can see. That's been a fantastic discussion and a great way to wrap up the 2025 series of Latin American key discussions in CML.